Maybe you can take on.
Good evening, everyone. On behalf of Meduzane, I warmly welcome you all to ONCOVISION '26, an insightful expert talk session themed Oncology Uncovered, Career Challenges and Calling. We are delighted to have participants joining us virtually from different places. Thank you for taking the time to be here today. Today's session is an opportunity to explore oncology not just as a medical specialty, but as a meaningful journey shaped by science, compassion, and dedication. It's truly our privilege to host a distinguished expert who has dedicated his career to advancing cancer care and medical education. Please join me in warmly welcoming our esteemed speaker, Dr. K. Satish Srinivas, MD Radiotherapy, Professor and Head, Department of Radiation and Oncology, Sri Ramchandra Medical College. A heartfelt welcome to you, sir. We are
Good
honored to
evening,
have.
one and all. Good evening, one and all, and good evening to Sophia, our anchor for today. Please continue.
We'll now move to the highlight of today's program, the expert interview, where we'll gain valuable insight into oncology, its challenges, and the deeper purpose behind this field. To lead this engaging conversation, we have Shobhya, Joint Secretary of Social Impact Wing, who will be interacting with our respected speaker and guiding us throughout today's session. May I now invite Shobhya to kindly take over and begin the interview. The virtual stage is yours.
Good evening, everyone. Thank you, Akila, for the warm welcome. It's indeed a pleasure to have Dr. Satya sir with us today. We're eager to listen to your journey, sir. Sir, we had loved to begin from your MBBS days at Madras Medical College. Was there a particular moment, maybe a patient encounter or a clinical posting, which first sparked your interest in oncology, or to be specific, radiation oncology?
A very good evening to all the viewers of Medicine and to the anchor, Sophia. So to begin with, actually, I did my MBBS from Madras Medical College, and it was the early 90s. Unfortunately, one of my colleagues, he was diagnosed with cancer, and he fought with the disease as a brave heart, and ultimately he succumbed to it when we were doing our internship. So seeing him from close quarters, like it was at that time when we really understood the impact of the disease, not only on the patient but also on the family. And I also came to know about the different, nuances of treatment and the side effects which somebody undergoes. And this actually probably would have been, a kind of motivation to get into this course. Now, this would be one of the reasons. And another reason was at that time, so initially in those days, we were moving over. There was a paradigm shift in the way medicine was evolving. Initially, we as students, we were seeing a lot of infectious diseases, and it was at that time when we started moving over from the infectious diseases to the chronic diseases. So in the OPD, slowly the number of cancer patients we were seeing started to increase, and we found that most of these patients in those days, unfortunately, did not, have a very good outcome as far as the treatment is concerned. So this again was, a reason for me to basically look at this specialty, which was in those days just coming up. It's not like your cardiology or neurosurgery and neurology, which actually had been quite well established in those days. So oncology in the 90s was just starting to blossom as a very important specialty in the country. So these probably were all the reasons which made me take up this particular branch.
That must have been an impactful start to your journey. So, were there any mentors during that time who shaped your thinking process, or someone who inspired
I
you
can think of
through
few
this
of them.
journey?
Yeah, as far as the mentors were concerned, I think the most important mentor was my own mom. My mother was Dr. Shamla Devi. She is no more now. She was a molecular biologist in her own right, and she was a scientist. She basically had done quite a lot of work on cancer therapy and in identifying the pathogenesis of cancer, as well as trying to develop new drugs and mechanisms to reduce the side effects of treatment. So watching her at close quarters, basically, I mean, she was probably my first motivation, to take this up as probably a career aspect. The other important reason was kind of one of my close friends. So he is a very big surgical oncologist today. So he was kind of a mentor for me when I was in my UG period. He was doing this post-graduation. We were good friends. And when he joined oncology and he motivated me, actually, I also wanted to initially take up surgery as who basically kind of opened my eyes towards this branch of radiation oncology. And I mean, the rest is history because I took this up as my career.
Yes, sir. Okay. And moving forward, you went on to complete your MD in radiation therapy and trained at premier institutions like JIPMER and Adyar Cancer Institute. So, how would you
Yes.
describe those early years? Were they more of overwhelming or exciting, or would you say it's a mix of both emotions?
See, I was fortunate to basically work in some of the premier, cancer centers of the state. Back in Barnard Institute, which is the radiation oncology department at Madras Medical College, we had a plethora of patients. Like you'd see the same disease in multiple stages of presentation or OP. There was never a dearth for clinical material back at Barnard Institute, and even today it is the same. So one of the best places where you pick up your clinical acumen and your clinical training is in the government hospital, where we have a huge crowd of patients visiting our OP, and I mean where we get exposed to the clinical nuances of training. And then when I joined JIPMER was basically is a central government institute, so it had more infrastructure in comparison to the to Madras Medical College in those days. Now almost all the institutes are on par as far as technology is concerned. But definitely JIPMER had a slight leading edge with respect to the equipment with which we were treating cancer. And so I was exposed to that technology in JIPMER. And finally, when uh, I got employed as a faculty at Cancer Institute. Cancer Institute is a premier center in India. I mean, it has all the latest facilities for managing cancer. So I was able to use the clinical knowledge as well as the technical knowledge. The clinical knowledge picked up at Madras Medical College and the technical knowledge picked up at JIPMER, and employed for patient treatment. Because unless you start treating patients and you see your results, you don't develop the confidence to move ahead with your career. So I was fortunate basically to have the best of whatever facilities we had in the state.
Mm. That's great to know, sir. You had like a proper mixture of both different exposures. And I guess that would have been like a mix of emotions as well. And it has taken shape beautifully, sir.
Yes.
And from our understanding so far, radiation oncology seems to be a blend of different subjects, fields like physics, biology, and clinical medicine. Was
Yes.
adapting to this multidisciplinary field initially challenging?
It is. It is for anybody. See, basically, radiation oncology is a broad specialty. That means immediately after MBBS, you join this program. But this clinical program, you have not only the routine subjects like medicine, surgery, and pathology to contend with. You also have to be good in certain abstract branches like radiation biology as well as physics, which is new to a MBBS graduate. So realizing this, I think now the NMC has made it an optional posting. Radiation oncology is an optional posting in your final year. You can opt for this posting, say, for around 2 weeks. We at Ramchandra get our final year students routinely every year for the past 2 3 years. We have been, they come and join us as observers and get oriented to this branch. And see, in those days when we didn't have this orientation, it was definitely a completely new ball game altogether when we joined us. It took us at least a month, a month and little more than a month to get used to what we were basically doing, the daily routine. And then, understanding the radiation biology and the physics, it took its own time. And this is where we basically need the help of our seniors, the senior postgraduates, because they were very helpful towards us and basically in trying to explain to us certain difficult concepts which we faced as undergraduates. Because of course the teachers are there, but you can't approach the teachers every other day with the small and silly doubts. So this is basically where your seniors do help to fill the void. So I think that part of training is very important. The relationship with your immediate seniors in the department as postgraduate, they also serve as a very important bridge to you. So we need to have a good relationship with them, and then things become slightly easier for us.
Okay. So just a small request, can you please position your camera a bit like facing the...
Yeah, is it okay now?
Yes, sir. Yeah, that's fine.
Yeah, yeah.
Yes, sir. So from what you had mentioned, we see that there would have been a lot of firsts in your journey. So, in similar to that, was there any particular skill which you had seen for the first time that took a little more time and practice before you were truly confident about it?
Yeah, there are many firsts. See, when you finish your post-graduation and come out, right? So by the time there had been a slightly, there's a different change in the way radiation oncology was viewed. New machines like linear accelerators had already come into the Indian clinical scenario in the mid 90s. So unfortunately, in the government hospitals in those days, we had only the relatively older equipment called as the telecobalt. So the minute I joined as a senior resident in a central government institute like JIPMER, I had to immediately adapt to the difference in the planning we do for a patient using the telecobalt and the planning we do as radiation oncologist for a patient when we use an equipment called as a linear accelerator, particularly when it comes to higher techniques like conformal radiation, right? So I had to adapt very quickly, and that was a bit difficult. But anyway, over a course of time, we were able to make this gulp, because unless you do this, you have to keep in trend with the new technology, particularly if you have to survive, because the world is very competitive. So this problem many people might be facing, because as I'm talking now, science will develop, and a lot more new techniques will come up when we open our laptops tomorrow and see. So we have to keep abreast, we have to keep updating our knowledge. And particularly in a branch like oncology, a lot of new things are discovered very frequently. And as oncologists, we have to keep updating what knowledge we have. So this is a big challenge. And initially, it took some time for me to get used to this.
Okay. So it's very important to keep adapting to the recent advancements
Yeah, you
to
have to
keep
read
pace
every
with the
day.
other.
Almost
Yeah.
every day you have to read, because there are a lot of trials, a lot of studies, particularly in oncology. And it might not be the same for other branches, but for this branch, definitely we need to update ourselves periodically.
So what's remarkable is that you didn't just practice oncology, but also took the initiative to build some departments. Like you had established the modern radiation oncology services at SVIMS, and later when had set up a state-of-the-art unit at SRMC Ramachandra. So that's
Yes.
commendable. And
Yeah.
I'm sure this process would have had its own highs and lows. And during these times, did you ever feel moments of doubt, or like did you wonder if everything would fall into place?
Yeah, starting a radiation oncology department is a very big game, because a lot of money is involved. And when we started the project at SVMS, it was completely with government funds and the funds of the trust. So we are answerable at every point of time to how this money is utilized, and then we have to also see that the department runs properly, and it is useful to the society, and we maintain good healthcare, quality healthcare to the public. So this is a huge responsibility, and mind you, the radiation oncology department is the only department which is answerable to the government on a day-to-day basis, because whatever we do, whatever treatment we do, whatever safety measures we take in the department is all governed by a central body, which is the Atomic Energy Regulatory Board. So nothing moves without their approval. So everything has to be perfect, not only the documentation, but also the quality of treatment that we provide. Everything is reported to them on a periodic basis. So it's not just that, at the beginning we maintain the quality and then it goes away. It has to be maintained on a day-to-day basis and for the complete life of a department. So that's a very big challenge, mainly the infrastructure, and then getting it organized, getting the regulatory body approval, and then periodically getting these inspections done by them. And if they identify any shortcoming, correcting it. So all these things are major challenges. But that's where you have to pull up your socks and show your mettle. So I had the privilege of starting a radiation oncology department, both for the government and for the private sector, which I think is slightly something which not many people would have achieved. And fortunately, both these departments are today running very successfully. And they've had PG programs, and several thousand patients have been treated in both these departments. So, thanks to the Almighty, this was all possible only with His grace.
Through all the challenges, I must say your efforts and dedication has paid off very well. And over the past few years, you have also been able to reach to like n number of patients from different backgrounds. This could also reveal the emotionally draining side of this field. So, how do you personally cope up with difficult outcomes or losses?
The first thing which I tell anybody who wants to take up a profession in oncology is that they should be quite strong, not only physically but also mentally. See, because particularly in radiation oncology, we travel with the patient for a significant part of his life. See, every radiation protocol or treatment will run into weeks. See, it's unlike any other form of treatment where you see the patient for 1 or 2 days, and then they get discharged, or they come subsequently for a review several months later. Radiation oncology is not like that. The radiation treatment normally for a patient it lasts for around 6 weeks, a curative treatment. So now after that, the patient will be reviewed periodically. So some of the patients, who get cured, might over a period of time relapse. Now that's the way the disease biology is. It's not your fault. Some diseases will recur, and some of them where you think that nothing can be done dramatically, they might respond very well to treatment, and they may defy science, and they may live long. On the other hand, there may be patients who are coming with a first stage disease, and they might not get cured. So anything is possible. So we have to have a strong heart, and we should also be good counselors. So most of these patients not only have somatic issues or physical issues, they're also extremely they have a lot of psychological issues also to be dealt with. The depression of having the disease, and the fact that society might shun them, or that the family might not accept them back, and they might have a lot of issues regarding how they are going to get economically they're going to go back to get their work, or whether at the workplace they might lose their job. There are a lot of conflicts which keep going in their mind. So we are not only doctors, we are also counselors, and we try to help the patient emotionally, and try to rehabilitate him not only physically but also emotionally back to where he belonged in the pre-disease state. So that is basically the challenge. So we have to be patient, and we also have to develop the habit of empathizing with the patient. We have to put yourself in the shoes of the patient, and then think how you would want the doctor to treat you. So that's basically what I do whenever I see a patient, because we see patients from different streams of society. We see the very poor, we see the poor, we see the middle class, and we see the upper class also. So each one has their own what do you call that desirable outcomes of the treatment. So accordingly we will have to tailor the treatment and also deal with them. So that is basically the challenge in this particular profession. And we also have to be mentally strong, because some of these patients might not make it and they might leave us. So we should not get affected by that loss. We have to continue to do our duty to the best of our ability.
Yes. So could you share with us any case that you remember or that has stayed with you over the past few years that could have maybe changed you not just as a doctor but as a human being itself?
Many cases. So see, actually I've treated mothers and daughters together, husband and wives together, mothers and sons together. So, like different sets of patients within the same family. Now, that's very, very sad, because you would just have one member of the family coming out of the disease, and then suddenly another member of the family develops the disease, and again the entire process starts. Then I've treated many ladies who during the pregnancy have been identified with the disease, and somehow we have tried to save both the parent as well as the child. And then there have been many children who have had treatment with me, because I treat quite a lot of pediatric cancers too. I give radiation to them, and some of them have become doctors today. So that's you feel very proud that you also help them to achieve uh, what they would have otherwise if not for the disease. So that makes us feel very happy that we have helped these children to develop professionally.
Mm. So you have made like a significant impact on many people's lives so far.
Not only me, many oncologists have. See, oncology is somehow a branch which is not very glamorous, if I could use the word, for most of the students, because you don't get the same recognition which a cardiology or a neurosurgery or a ops gynae, gets. But these guys, these oncologists are basically unsung heroes because it's a long day
Yeah.
and
And
they help most of these patients to get back their life. So, and they are revered as demigods by the patients because most of the oncologists for the patients, they are the people who help them, to come back to the normal life. So they're given a lot of respect by the patients and their families. So definitely, it's a branch I think which most students should consider.
okay, sir. And sir, alongside clinical work, you have also guided multiple PhD scholars and even published extensively. What motivates you to stay involved in research beyond this busy schedule?
As I said, the basic motivation towards research came from my mother. So she was a double doctorate and she had more than 100 publications of her own. So basically, the interest in research came from her. And being an oncologist, automatically you have to be interested in research because see, nobody has still exactly found the remedy for cancer. We have established treatment protocols which modify the outcome of disease, but still we are not gone to the core and say that with this particular treatment, this particular patient will never get back the disease. So that has still not happened. So still, this particular branch needs a lot more research and a lot more treatment options are to be discovered to make these patients safe from the disease. So all oncologists, in turn, I mean, have to do. They are also researchers. In an academic institute, definitely have to be a part of the research, and it basically stimulates me to continue to go forward because nothing like identifying new treatment outcomes which might make or the life of the cancer patient better. So that's a very big motivation to stay focused. So in fact, nowadays my research priorities are slowly going above my clinical priorities because there's a lot avenues opening up in this country as far as research is concerned.
Yes, sir. So, with extensive research papers and emerging technologies, we see radiation oncology transform rapidly. What's your
Yeah.
opinion on this? Like, how do you see radiation oncology transform over the next decade?
See, radiation oncology today is exactly at the point where radiology was 2 decades back. So when I was basically a undergraduate, a lot of new developments were happening in the sister branch of radiodiagnosis. So I'm seeing radiation oncology today in the same point where probably radiodiagnosis was 2 decades back. A lot of new technology is coming into radiation oncology, and we are looking at more personalized treatment options for the patients and more high precision treatment options. So we are coming to a point where we'll be, with the help of radiodiagnosis, we'll be able to exactly locate the disease and give a tailor-made plan wherein we try to ablate the tumor without significantly damaging the normal tissue. And with India having the first uh, proton unit at Chennai, and now the second unit having come up at Mumbai, and probably another 2 or 3 units would have come up by the this year end or the middle of next year. I think definitely radiation oncology as a treatment specialty is going to grow bigger in this country, and the future is very, very exciting.
Okay, sir. I would also like to give you a debatable question. Do you
Yeah.
think artificial intelligence will replace radiation oncologists, or do you think it will enhance the human element of this work?
See, AI is going to be an indelible part of our life. It's not only going to challenge radiation oncology, it's going to challenge all aspects of medicine, even clinical medicine, surgery, right? So radiology, pathology, it's actually encroached. And but what we have to realize is AI cannot take the place of the doctor. See, basically, it assimilates the information which we feed into the program and gives you a more in-depth analysis of the data which you have provided. So you are the guy who's providing AI the data, right? So as long as we accept the technology and embrace it, we'll be able to harness it and use it for our needs in a better way. But definitely AI cannot replace the role of the doctor. For example, in radiation oncology, today we have what is called as adaptive radiotherapy. Adaptive radiotherapy means on a day-to-day basis or probably on a less frequent basis, we have certain software, which can analyze the response of the tumor to radiation, and it will itself give newer plans, which for that particular day might be a better plan than what we have given at the beginning of the treatment. So this technology is now fast. It's coming up in a big way, and probably it might replace the existing technique what we are using. But ultimately, it is a doctor who has to use it for the patient. The people are not going to go to the AI and get themselves treated. So AI is definitely a necessary, like it's definitely going to be an important part of everybody's life in every aspect of life, whether it's commerce, economics, everything. And we should embrace it in the right way. But AI cannot, replace the role of a doctor.
I think most of us here would agree to it as well, sir. And sir, balancing multiple responsibilities in one go is not easy, like balancing clinical practice, administration, research, and teaching altogether is definitely not an easy task. How have you managed this balance in your personal life?
Well, okay, that you have to ask my family because they'll be the better judge whether I'm a good father or a good husband. But see, definitely, I have to thank my wife because she's a professional too, but she bears a bigger load of the family responsibility. But yes, I've been in administration for several years. Since my days since when I started the department, I've been an administrator. I've been taking care of the department for more than a decade and a half, or nearly two decades now. So it is a lot of responsibility, and you have to do multitasking. And, you have to, manage it. And sometimes, yes, I have not been able to keep certain family commitments. For example, I might promise them to take them out for dinner, but a patient might fall sick, and I have to stay back and take care of the patient. But I think that's a part of every doctor's life, right? As you become older and you have more responsibility towards the patient, the family has to understand, and probably the weekends or the Sundays are meant for the family.
So
But
this
this, of course,
constant
even a
juggle would have,
gynecologist or a surgeon will have the same problem. They might have to sacrifice the family to a certain extent to take care of the patients, because you never know when emergencies are going to crop up.
so this constant juggle would have also pushed you to like a higher chance of burnout, right? So how do you avoid burnout in your practice?
Yeah, see, basically, we have to develop other interests. This is quite a challenging branch, as I said, because emotionally also you get drained out because you travel with the patient, and the patient looks upon to you not only to solve the medical problems. Sometimes they look upon to you to solve a lot of other problems also, even personal problems, and sometimes even economics comes into the play because the patient might have an economic void during the middle of a treatment that was a fag end of a treatment. So for that also you might have to give him some form of solution, look towards NGOs or somebody to fund the treatment of the patient. So there's a high chance that you can get burnt out. For that, you have to develop other interests. For example, my other interest would be reading, and I do astrology. I'm highly interested in music, in writing, in listening to music. So you have to set aside some time for that, and divert yourself. Otherwise, definitely you will get burnt out.
That's a great advice for everyone here, actually. So, apart from this, do you have any advice for our audience, the aspiring oncologists, to excel in their career or say to have a head start in their journey?
See, very simple. See, you may take up any part of any branch as your in your post graduation, or you can even stop with MBBS. It's your option. But the point is, you must try to excel and try to be the best in whatever you do. Now, that would be the best advice I'll give. Try to put 100% effort, right, into whatever you do. Always think of the patient as everything for you, because without the patient there is no doctor. So he's everything to you, and try to do your best for him, and never give up ethical values in your life, right? Never compromise ethics for economics. So if you follow these small principles, definitely you will make it as a very successful doctor. See, always a doctor who is available to a patient is the best doctor. You don't have to be a doctor with multiple degrees, you know, but if you are available for the patient in his time of need, he will remember you for the rest of your life. So as far as people who want advice in oncology, as I said, you see, basically you will have to have an aptitude for this particular branch as far as radiation oncology is concerned. And you will, as I said, you have to update yourself periodically. So you have to be slightly hardworking, right? And see, once you work hard, the rewards will automatically come after some time. And you have to do your post graduation, which is around 3 years. And then you may have to do a residency or a fellowship to get trained. And over the period of time, I think over the next few years, we will have organ-specific radiation oncology coming up. Right now, I treat almost all sites, but this might not be the way in the future. You may have subspecialties coming up like head and neck radiation oncology, thoracic radiation oncology, genitourinary radiation oncology, musculoskeletal like that, and central nervous system. So there will be all. After you do your MD, you will be doing a fellowship or a DM program with these site-specific oncological programs in place. So you are looking something like another 6 to 8 years of education, and it's only after that you will start being economically rewarded, and you'll start making a name. So during your period of education, try to put a lot of publications, try to do certain courses, value added courses, which is going to keep you ahead in the race, and keep you so that you have an edge over your competitors when you go for an interview after your PG program. So never stop learning. That's basically what I would like to tell my young undergraduates as far as oncology program is concerned. You have to be up to date, because your patients like doctors who are up to date, right? You're competing, as you rightly said, with AI. You're competing with new technology. All your patients are tech savvy. They are the generation next patients. So you should know little more than them. It's only then that they will have the confidence in you. So you have to be up to date.
Yeah. So, would you also like to add something about early exposure during MBBS days, or if like research projects actually add on to the students if they are going to
Definitely.
pursue this field?
Nowadays, I think the ICMR and the NMC, I think they are making it more friendly. They're creating a friendly environment for undergraduates to start research. Previously, that was not the case, but I think now they are starting up new UG research projects. Even in the institute where I work, we have a lot of summer research fellowships for undergraduate students, and they write research projects, and we mentor them as depending upon whichever branch they want to do some research work on. But the point is, completing research project is not enough. You have to publish that work. So where we lack in comparison to our Western counterparts is in making publications out of this research. You might have a good, good innovative idea, but unless you publish it, there is no value. So I think we should take some time off and write the project, try to get a grant, complete the project, and then make a publication out of it. And then that is where the success lies.
Okay, sir. I think we are coming to the end of the session. If any of the audience has any questions to pose, please share in the chat box.
I'm free to take any number of questions, so don't hesitate. No question is a stupid question, so it will be answered if I know the answer for that. Either I made a lot of sense, or I didn't make any sense. So probably the latter, I think. So why don't you tell me something about medicine, Sophia?
Yes, sir. It's basically like a student-led organization, and they have like various clinical-based YouTube videos, and they're doing it just out of interest and for the benefit of students. So it was initially started by Dr. Raghu sir. He's also in the meeting, and he has made a team uh, of students now. And I guess it has expanded so much over the past year, and now we're trying to build it further.
That's nice. That's very nice. We never had these kind of opportunities when we were undergraduates. So I think that's very nice that somebody is mentoring them, and this is the right age for them to get mentored because, see, they should actually know what their interest is in, right? So, like some of them may say, I want to be a physician, I want to be a surgeon, but if they don't have the aptitude for that particular branch, then it's too late to correct it once you go down that particular path. So I think
That's right.
opportunities like this definitely are needed for the younger generation to identify basically where their talent is and what they need to do. Because at
Yes,
the
sir.
end of
I
the day,
think
you
we
must
have
enjoy your.
an yes, sir. I think we
Yeah,
have
please.
an added advantage with regards to that because we get
Yeah,
better opportunities to learn more about these.
yes.
So we have two questions in the chat box.
Yeah, please.
So Aditya is asking, how different is medical oncology from this branch?
Okay. So basically, in oncology, there are three main branches. If you look at historically how they evolved, surgery came first, right? And in fact, the Indians were pioneers as far as oncological surgery was concerned. You'd have heard of Shushruta. So he was a pioneer, and the first recorded oncological surgery was done by him when he removed a lump from the chest. So subsequently, after that, radiation oncology evolved as a science, and this came out came about basically because of the discovery of X-rays by Röntgen. So that was in the year 1895, and after Röntgen discovered X-rays, its diagnostic use was first identified, and subsequently they started using these X-rays in treatment of cancer. So, and that happened both in the US as well as in Europe around the same time. So, after that, medical oncology evolved much later after World War II as basically a branch which could help to treat cancer. And it has actually shown the maximum growth, although it had a late start, say around the 60s and 70s. Today, it has diversified into regular chemotherapy, targeted therapy, biological therapy, as well as the immunotherapy, which is extremely popular today. Now, radiation oncology, we use X-rays and we use gamma radiation as well as protons from radioactive elements to treat cancer. And how this basically destroys the cancer cell is it inactivates the DNA. We damage the DNA and thereby prevent the ionizing radiation damages the DNA and prevents it from replicating. That's the way the radiation oncology works. So we are a branch which depends upon our machines. So we either need the teletherapy machines like the linear accelerators and brachytherapy machines, which uses radioactive isotopes to deliver the radiation. On the other hand, medical oncology, you need just the drugs. So you can deliver it in any hospital. You don't need to have sophisticated infrastructure like a radiation bunker and a machine placed. Any ward which has, a biological safety cabinet to mix the chemotherapy drugs, you are just going to administer this through the intravenous route, or you can also give it in the form of tablets. Rarely we give it through parenteral routes like through the peritoneum or through the spinal cord. Through the spinal cavity. Otherwise, most of it is done mainly through the intravenous route or through the oral route. That is as far as medical oncology is concerned. So that is the basic difference. Here we use X-rays predominantly to radiate the tumors and to cause DNA damage and prevent them from growing. While here we use drugs through the intravenous route or tablets to take care of the cancer. The other fundamental difference is radiation oncology is a localized form of treatment. The difference between surgery and radiation oncology is in surgery there is loss of tissue and there is loss of function because you remove the tumor. Sometimes you may have to remove it with a significant part of the organ, so there will be a functional loss. Radiation oncology is just like surgery; it's a localized form of treatment, but we are preserving the anatomy here, and there will be some functional loss due to radiation, but it might not be so bad as that of surgery. But chemotherapy, well, it takes care of the disease in all parts of the body because we are giving it directly into the blood, into the intravenous route or intraarterial route. So this drug will go to all parts of the body. So it might have an effect, will have an effect locally. It will also have an effect in other parts of the body through the blood where the disease is likely to go. So most of this chemotherapy is reserved as a primary treatment only in the advanced stages of cancer, while radiation and surgery are used in all the stages to give the local treatment.
Next, we have another question. Joel is asking, what are the skills that an MBBS student needs to start developing if they're interested in oncology?
Well, if they are interested in oncology, as I said, first you have to develop a strong mind, willpower, and you, as I said, in your final year, you have to get yourself, posted in any one of these departments because you get postings in radiation oncology, surgical oncology, medical. You have to opt for that, whichever subject you want to take up, and first check whether this branch is cut out for you because you will be seeing a lot of patients suffering. You will see a lot of the disease affecting not only the patient physically but also socially. So whether you are up to the challenge is what that observational posting will teach you. And still, yes, if you're interested, then take it up as a branch.
Okay. We have another question from Karthik. He is asking, what role does a multidisciplinary team play in cancer care?
It's a good question, actually. See, today, everything is about multidisciplinary care. So the recent guideline is any patient before treatment should be seen by the multidisciplinary team, which consists of the surgical oncologist or the any other surgical branch which is going to give the surgical care for the patient, the radiation oncologist, the medical oncologist, the pathologist, and the radiologist. And in cases, suppose a patient has is a child, there'll be a pediatric oncologist, or if it's a hematological cancer, there'll be a hemato-oncologist. In case the patient wants to conceive after the treatment, there'll be a fertility specialist in the stream. So all of us will discuss the patient's condition, the stage, and what are the components of treatment that we have to give him, and in what sequence it has to be done. And all this will be discussed in a forum which is called as the multi-speciality tumor board. So nowadays it's mandatory that every cancer case before the treatment is given, the case is discussed in the tumor board and the decision documented and then implemented. In case there is any change in this particular decision, once again that case has to be brought back to the tumor board and the decision has to be ratified or amended. Now this is because this is to see that there is a protocol-based treatment which is given for every cancer patient because there are a lot of protocols in place and it's the responsibility of the multidisciplinary team to give protocol-based care to the patient. And we also have to see that there is a nuance of personalized care also involved in the treatment. So every case is today discussed in a multi-speciality tumor board. That is at least how the premier cancer centers work. Small nursing homes also have started to adopt this strategy, and they're trying to engage people. If they're not physically present, they conduct a virtual tumor board and get the policy, drafted and documented in the patient's file. This is also nowadays becoming a legal requirement. In case tomorrow there is a legal issue regarding the outcome of a particular treatment, if the case has gone through the board, usually then they accept that some form of protocol has been followed in that particular treatment.
Okay.
So multidisciplinary care is everything.
Okay. And we have one last question. How to use AI in the best way for oncology aspirants?
So AI in oncology, see, it's there in diagnosis. It is there in treatment. It might also come up in a big way in prevention, like in screening and things like that. So as far as today where AI is, in pathology, we have what is called as digital pathology, which is coming up in a big way. So the same slide can be seen, by multiple doctors at the same time. I can get consensus on a rare cases, right? Also, basically, nowadays we see that when a pathology report is made ready, the pathologist will ask for certain tests called as immunohistochemistry test to confirm the diagnosis. It's not done for all cases, but certain scenarios they will be asking for this. Now there are a plethora of immunohistochemistry studies which can be done for a particular tumor. The AI will help in predicting what is the most what is the best set of IHCs which is needed for this particular morphology to come to a diagnosis. Like that today in pathology, AI is coming up in a big way. In radiology, we call it as radiomics. It is helping to predict, seeing, for example, we screen breast cancer with a procedure called as mammogram. Now, we need to have a dedicated radiologist who reads these mammograms to give a score for us to predict what will be the outcome of this particular lesion, whether it's already malignant or it's likely to be malignant or pre-malignant, things like that. So now radiomics is coming up in a big way, basically in those places where we don't have access to these radiologists. It might screen these numerous mammograms and help to select those which need to be read by a senior person and to decide whether the patient needs any further evaluation. So like this in radiation oncology, as I said, for adaptive radiotherapy, AI is coming in a big way. It will try to predict what might be the response of the tumor to a given dose of radiation and help you to select a particular plan for the patient. And it's like in even in surgery, AI is going to play a big role, in trying to predict which patient should be taken up for surgery and what might be the best technique and things like that. So it's a huge, world ahead for us. Probably you kids will be seeing the best of the AI in medicine, your generation.
So we have a few more questions. Can we take them?
Yeah, sure.
Yes, sir. So Joel is asking how to handle cases where patients come in very late stages rather than
Yeah,
stage 1 or 2.
there is something which is called as breaking the bad news. And that's something which you have to learn. It's done in abroad by counselors, but here in India, some centers have counselors, but most of the time, we, the doctors, are the people who break the bad news. So what I do is I basically tell the patient that he has a disease which needs this particular treatment and that we hope for the best. We don't go into the depth of the issue. Like we don't tell them that you have so many diseases, so many sites getting affected, and that you're going to, live only for this. We don't necessarily frighten them, but we inform the family that he does have an advanced disease, and this is what we intend to do, and whether we are likely to, what are the percentage or what are the chances that we might succeed with the treatment or the side effects that he is going to face. But they have to also be prepared that in case the patient doesn't respond, we might have limited options and that he might be suitable only for supportive care of end of life care. This is what basically we counsel the family.
So we have another student, Abhinav, who's aspiring to pursue oncology, and
Yeah.
he's not sure about which field of oncology to go for, like medical, surgical, or radiational. So he wants to
Okay,
know
very, very
what
simple.
to.
Very simple. If you have an aptitude for surgery, go into surgical oncology. Of course, you'll have to do your MS general surgery first and then do your MCH in surgical oncology. If you're a good physician, you're good in your clinical work, or for medical oncology, do your general medicine or pediatrics and then go for medical oncology. If you like, physics, then basically you become a radiation oncologist.
That's a simple answer.
Very simple answer.
So we have one last question from Karthik. He says
Yeah.
that many people fear cancer and delay seeking medical help. So it often results in advanced stage diseases, which is difficult to treat. So he's asking, how can we encourage patients to seek medical attention at the early stage?
See, the entire problem in the country is that, see, why are the foreign countries, seeing more early cancers, and why in our country we see more late cancers is because of this lack of awareness of the signs and symptoms of cancer, and the fact that even when the patient knows that they have a problem, they are afraid to approach a doctor because of the fear that they will be ostracized by society and their family. They leave it to a stage when it is too late, when they cannot continue with their routine life when they approach the doctor for help. Now, abroad, what happens is most of the healthcare, at least 70%, 80%, is provided by the government through the NHS, right? And as part of the NHS, mandatorily, the people have to undergo certain tests every year, not only with respect to cancer, with respect to the general health, and also specifically for cancer, because this helps in identifying disease in a very early stage. This concept is called as screening. Now, if you don't get undergo these tests, they don't renew your contract the subsequent year for the medical care. Now, unless something like that happens, we are not going to get more early cases, because right now, this onus has been left into the hands of the people. Because of our huge population, it's very difficult for the government to provide healthcare for everybody. Of course, our state and certain other states in the country have started through the government schemes, wherein they are trying to cover the underprivileged people under the health insurance scheme. But even there, it is only people who come with symptoms who get treated. As far as cancer screening is concerned, still, we have only touched the tip of the iceberg. The day when all of us start getting ourselves, now I'm not only blaming the general public, even doctors don't get screened for cancer, right? How many of them, I mean, like breast self examination is supposed to start by 18 years of age. How many undergraduate students are doing breast self examination, or how many doctors who are, above 25 are doing breast self examination or getting a pap smear done? So it's basically one, the lack of awareness, and second, the lack of will, both in the educated and the uneducated. So unless this trend changes, we are not going to see early cases coming up. But in comparison to what I saw as a undergraduate and then a postgraduate and then a junior consultant now, there's a lot more awareness, right? Definitely the educated part of the society today is definitely coming forward in a big way to get themselves screened for cancer. The fear of the disease, and now cancer has become very common. There's almost every family who has somebody known to them who's having the disease. So the fact that this disease numbers are increasing, more and more people, particularly in the educated segment of society, are now coming forward to get themselves screened. So this is a welcome change, and that's why we are detecting quite a lot of breast cancers today in a very early stage. So, but this has to, permeate through the entire society, and not only just the educated or the upper class. Almost all the classes should come forward, because the screening is done in a asymptomatic patient. When a patient has symptoms and he comes, you don't call him as a patient who has come for screening. He's come as somebody who's come for a diagnostic test. So a person who's asymptomatic, right? And they should come regularly. The screening is not a one-off test. This has to be done at a periodic interval. So unless this mindset changes, then only we'll be seeing more early cases. As a part of this initiative, February 4th is basically celebrated as a World Cancer Day all over the world. And basically, the whole motto of this World Cancer Day is to draw awareness to this disease. And the fact that people should basically come forward and get evaluated for cancer rather than leaving it to a very late condition. So that is the basic purpose of celebrating this February 4th. And I'm very happy that in this month of February, I'm talking to you all regarding this particular concept.
Yes, sir. Actually, this session is itself a part of the World Cancer Day event.
Great.
So,
Yeah.
like from the month of World Cancer Day, we had started with multiple sessions, and this is one of that. That's why we wanted like an expert talk from an oncologist. So
Yeah.
apart from this, we also had something for early screening and awareness, and about nutrigenomics and nutrition's role in cancer care and those kind of sessions. But
You
it's
should
very
have one
happy to
session
have.
on myths about cancer, because there are a lot of myths about cancer which even the medical fraternity doesn't know.
Mhm. Sure, sir, we'll consider that.
Basically, an MBBS student should also know to counsel. See, what happens is, once you become a doctor, everybody comes to you as the point of reference in your family, right? Everybody will ask you, and they'll expect you to answer these questions also. So there, unfortunately, as far as oncology is concerned, the quantum of exposure, of course, it's now slightly different, but it needs to be improved upon, because cancer is today the third or the fourth most common condition you're going to see in practice. The first is going to be diabetes, next is cardiovascular disease, the third is neurological problems, and the fourth is cancer. And this cancer is likely to become the second most common condition you're going to see in by the next 15 years. By 2030, 40, this is going to be the second most common condition in the country. Of course, diabetes will always be number one in our country. So then the amount of knowledge which an undergraduate has as far as oncology is concerned, right now, as per the curriculum, is very less to cater to the needs of society. So over a period of time, this will change, and probably the radiation oncology and the oncology postings will be made mandatory in your final year.
Sure, sir. We'll hope for the best. Yeah.
Yeah.
Okay. Is there anything else you would like to share before we move to the closing statement for the day?
Yeah, as I said, like you're all your final year, or your different years of medical
A mix of
mixed
various.
up.
We're
So
all
see, what I
LLB
like to
students.
say is, not everybody gets the chance to become a doctor, and God has selected you all into this profession basically. So what I see today lacking I mean, I won't say lacking. What I see is basically most of the doctors not developing that concept called empathy with the patient. There is a slight disconnect, right? Which was not the case in our generation. So I would try to reinforce that all of us will sympathize with the patient. Put yourself in the patient's shoes. Try to imagine if you are a patient, what would you expect in the doctor who's treating you, and transform into that, right? Because as I said, there is no doctor if there is no patient. He needs you and you need him also, him or her. So please develop that attitude. And also, as far as oncology is concerned, right, you have to understand that you only treat, but there is a power above all of us which cures, right? So you always have to have, because here you are curing, you're dealing with life and death every day. This is not like any other branch where you don't see such acutely sick patients. So you all have to develop that attitude also, that I will do my duty, I will treat my patient to the best of my ability, but ultimately I am not responsible for the net result. You don't decide whether he lives or dies. If you develop that attitude, you can accept both success and failure in the right spirit. That is very important in this particular branch, because you cannot cure anybody, you cannot cure everybody. At the same time, you can still make a mark and cure a significant proportion of your patients and be an indelible part of their life.
Thank you, sir. Akhila, can you take over and conclude the session?
So now I take the privilege to thank you on behalf of our entire Medusian team for sharing your valuable knowledge, experiences, and wisdom with us today. The session was beautifully inspiring and truly enriching. Thank you so much, sir.
Thank you, Ma. Thanks for the
Also,
opportunity. I thank Medicine for this opportunity. Yeah, thank you.
Thank you so much for joining, sir. Also, I'd like to extend sincere thanks to our interviewer, Shobhya, for facilitating such an engaging and meaningful interview here. It was truly amazing. Also, our
Thank you.
heartfelt thanks to our technical team, outreach team for their dedication and effort. So, because of them only, this online event was a success. And finally, we thank each and every participant for joining us, for your attention, and for making this session interactive and memorable. Let us continue to learn, grow, and serve with compassion and excellence. Thank you all once again. Have a wonderful evening and stay safe. Akila here, signing off, and bye.
Thank you,
Thank
Ma.
you for
Thank
the
you.
session, sir.
Thank you, Pa.
Thank you,
Good
sir.
night.
Thank
Thank
you.
you.
Good night.